Hello all, welcome back to my channel. This is Dr. Sonia Musakutti, and in today's video we are going to learn about suture materials and techniques. So before going into the topic, as usual, please don't forget to subscribe this channel, like, share and comment this video. Since this topic is huge, I will be dividing this topic into two parts. So in the first part we will be dealing with classification of sutures, indications of suturing, principles of suture material selection, types of suture needles, biological responses of our body to the suture material, and principles of suturing. So, coming into the topic, a suture is defined as a strand or thread of material used to approximate tissues. So, let's go into the classification of sutures. The sutures can be broadly classified depending on their size, thickness, resorbability, number of filaments, making process, etc. into following types: absorbable sutures, non-absorbable sutures, and coated and non-coated sutures. They are also classified based on the thread diameter, ranging from diameter or thickness from 10 to 10. The suture materials that are digested by the body enzyme or are hydrolyzed by tissue fluids are absorbable, and they are further divided into natural and synthetic types. The non-absorbable sutures cannot be digested by the tissue enzymes. They can be also further classified into natural, metallic and synthetic types, and monofilament and multifilament types. Primary indications include closing the dead space, supporting and strengthening wounds until healing, approximating skin edges for an aesthetically pleasing and functional result, and minimizing the risk of bleeding and infection. Now, let's move into the principles of suture material selection. The first principle is the rate of healing of tissues. The tissues that heal slowly, such as skin, fascia, and tendons, should be closed with non-resorbable sutures. And the tissues that heal rapidly, such as muscles, peritoneum, may be closed with resorbable sutures. The second one is the tissue contamination. Monofilament absorbable or non-absorbable sutures are used in potentially contaminated wounds. The third principle is the cosmetic results. The fourth one is the microsurgical procedures. In case of cancer patients, synthetic non-resorbable sutures are used. When the patient is undernourished and hypoproteinemic, non-absorbable sutures should be used. The suture size should be selected based on the tensile strength of the tissues. Now, let's go into the details of suture needles. The surgical needles are of two types, the eyed and the eyeless needles. The suture needles are also classified according to their curvature, radius and shape. The surgical needle comprises of three parts: needle eye or swagged end, needle point and needle body. The needle eye can be closed or swagged. The closed eye is similar to the eye of an household needle. The shape of the eye may be round, oblong or square. When the suture is attached to the needle via a hole drilled through the end of the needle, the end is swagged during manufacture. It is called as a swagged suture, and these are also called as atraumatic needles. After the needle eye, next comes the needle body. The body or the shaft section is usually referred to as the needle grasping area. The cross-sectional configuration of the body may be round, oval, side flattened, rectangular, triangular or trapezoidal. Next comes the needle point. The point is the extreme tip of the needle to the maximum cross-section of the body. The tip can be cutting, round or blunt. Cutting needles have at least two opposite cutting edges. They are ideal for suturing keratinized tissues like the skin, palatal mucosa, buccal and alveolar mucosa. Round or tapered needles are used for suturing soft and non-keratinized tissues like muscle, fascia and neural sheath. Now comes the biological response of the body to the suture materials. As we all know, the first response of the body, as in any healing process, is the invasion of the tissue site by neutrophils. If uncomplicated by infection or trauma, the acute cellular tissue response to the suture material changes in about 3 days after the implantation. The original population of the neutrophils is replaced predominantly by monocytes, plasma cells and lymphocytes. Small sprouts of fragile vessels infiltrate the area and eventually fibroblast and connective tissue proliferate. Assuming the same technique, tissue and other relative factors, the tissue response to all the sutures is relatively the same for the first 5 to 7 days. After this, the response is more related to the type of suture material used. Now let's move into the principles of suturing. The needle should be grasped at approximately 1/3 the distance from the eye and 2/3 from the point. The needle should enter the tissues perpendicular to the tissue surface. The needle should be passed through the tissues along its curve. The suture must be passed at an equal depth and distance from the incision on both sides. The needle always passes from the movable tissues to the fixed tissue. The needle always passes through the thinner tissue to the thicker tissue. Tissues must never be closed under tension. The suture should be tied only to approximate the tissues, not to blanch. The knot should never lie on the incision line. Sutures should be placed at a greater depth than the distance from the incision. Sutures on the skin are usually removed in 5 days and intraoral sutures in 7 days. If there is tension while suturing, the sutures may be kept for 10 days. So that comes to an end to the first part of suturing materials and techniques. In the next part, we will be dealing with a brief description of each type of suture material coming in both absorbable and non-absorbable suturing materials. And also, we will be dealing with the different types of suturing techniques and mechanical wound closure devices. Till then, it's Dr. Sonia Musakutti signing off. Thank you.